Welcome to the Deep Dive. We're digging into a stack of your sources today, all centered on a really persistent issue in healthcare, hospital readmissions.
That's right.
And we're going to unpack what this research, these articles are telling us about how artificial intelligence is being used or could be used to tackle this.
Yeah, looking at the data it uses, if it's, actually working.
And the challenges too, right? Because putting this stuff into practice isn't simple. Our goal is really to pull out the key insights from this material for you.
Exactly. And it's not just theory, as the sources point out. This has real consequences for patient recovery, hospital resources, healthcare costs, the whole system, really.
It also touches on that idea we see sometimes AI as a sort of co-pilot, assisting experts.
Precisely. Like one source mentioned AI helping with the mechanics of writing, but the human still drives the content, the critical thinking. Similar idea here in medicine.
Okay, let's set the stage. Why are hospital readmissions such a constant problem, such a headache for healthcare systems?
Well, they're a big deal for, several reasons. First, unplanned readmissions, especially within, say, 30 or 90 days, are a key measure of hospital quality. It reflects on the care provided.
Ah, okay. A quality metric.
Right. And they put a huge strain on resources. Beds, staff time, it all adds up. Studies consistently show significant costs associated with them.
And for the patient.
Oh, it's a terrible experience. You think you're done, you're recovering at home, and suddenly you're back in the hospital. Nobody wants that.
And for you listening, why should you care? Well, reducing readmissions means better care, a smoother recovery for patients and their families, and potentially lower healthcare costs overall.
Exactly. Which brings us to AI. It's being presented as this, potentially revolutionary tool.
How so?
The core idea is using AI models to predict a chance that a specific patient might end up back in the hospital soon after they leave.
So moving from being reactive, dealing with it after it happens,
to being proactive, using that prediction to spot the higher risk patients before discharge so you can actually intervene.
And machine learning is the engine behind this prediction.
That's the key technology here, yes.
Yeah.
Machine learning algorithms trained on healthcare data.
Okay, so what data are we talking about? Healthcare data feels incredibly complex.
It absolutely is. These models typically chew through huge amounts of historical medical data. Electronic health records, EHRs, are the main source.
So that includes things like diagnoses, lab results.
Yep, diagnoses codes, lab values, vital signs, medication history, even basic demographics like age and gender. The sources do suggest that using this richer EHR data gives better predictions than just using, say, administrative billing data.
And what about factors outside pure medicine, like social factors?
Good question. Some models are trying to bring in non-clinical data, too. Sociodemographic info, maybe pulled from other databases. Things like, ideally you'd want to know about a patient's living situation, income level, maybe housing instability or food insecurity, if that's documented somewhere.
But getting that kind of data sounds like a whole other challenge.
It's a major one. That comprehensive social risk data often isn't neatly structured or, frankly, even available in most EHRs today. There's no real standard for collecting it yet.
So the data itself is a hurdle.
Definitely. Even the clinical data in EHRs can be, messy, inconsistent. It varies a lot depending on how different hospitals record things. Variable construction, they call it.
So not just getting the data, but making sense of it.
Right. The sources point to a few key challenges here. Data variety and complexity, obviously. Then there's data imbalance. The fact that readmissions are, thankfully, less common than non-readmissions. That makes it harder for models to learn the patterns.
Okay, imbalance. What else?
Locality bias. Data from one hospital might reflect its specific patient population demographics, income levels, which could introduce bias if you try to apply that model elsewhere without care. And of course, patient privacy and data regulations are absolutely non-negotiable. Plus, AI used for a prediction like this is often considered a medical device, so it's regulated.
Wow, okay, lots of data hurdles. But let's get to the payoff. Is there evidence this AI prediction actually works in the real world? Does it reduce readmissions?
Yes, and this is where some of the sources get really interesting. They describe a specific study where a commercially available AI tool was implemented in a hospital, a regional hospital in La Crosse, Wisconsin.
Okay, a real-world test. What did the tool do?
It used machine learning, combining clinical data with some non-clinical information, to predict the 30-day readmission risk for patients. They rolled it out and tracked what happened over 6 months.
And the results?
They saw a pretty significant decrease in their all-cause readmission rate. It dropped from 11.4% before the AI implementation down to 8.1% after.
That sounds like a big improvement.
It was statistically significant, too, meaning highly unlikely to be just random chances. And importantly, when they compared themselves to similar hospitals not using the tool during that same period,
Yeah.
the hospital using the AI had a 25% relative reduction in readmissions compared to those control hospitals. Also statistically significant.
25%. So this source suggests it's not just hype. It can actually make a measurable difference.
Exactly. It provides solid evidence that, yes, AI prediction can help reduce readmissions in a practical hospital setting.
Okay, so the AI flags patients as high risk. How did that translate into fewer people coming back? Did they just apply interventions to everyone?
That's a really crucial part of the findings. The AI assessed patients on general payer units and basically identified the top 20th percentile as high risk. I think it was around 600 out of 2,400 patients assessed, roughly.
So about a fifth of the patients.
Right. And the key finding was that the overall drop in readmissions was almost entirely driven by the reduction among that specific group, the ones identified as high risk, who then received targeted interventions from the hospital staff.
Ah, so focusing the effort makes sense. It's more efficient.
Absolutely. The study even quantified this using something called the number needed to treat, or NNT. Basically, how many patients need the intervention to prevent one readmission. Overall, the NNT was 30. But for just that high-risk group identified by the AI, the NNT dropped way down to 11.
Wow, only 11. That's much more targeted.
It strongly suggests that using AI to pinpoint who needs the extra support allows hospitals to use their resources, staff time, specific programs much more effectively. Focus on where it counts.
That makes a lot of sense. But you said interventions. The AI predicts, but humans act. How did that partnership work? Did the AI tell them exactly what to do?
This is another really critical insight from the sources, especially the lacrosse study. Prediction alone isn't the magic bullet. Its impact hinges on being coupled with effective, patient-centered interventions delivered by the healthcare team.
And what did the staff think about the AI's role in that?
Interestingly, the feedback was mixed. They valued the AI's ability to flag the high-risk patients, that was clear, but they often felt the specific recommendations generated by the AI weren't always that tailored or useful for the individual patient.
Like generic advice.
Yeah, sometimes the same recommendations for patients who seemed quite different. The real value, staff reported, came more from the AI prediction acting as a prompt. It spurred multidisciplinary discussions.
So the prediction started a conversation.
Exactly. It got doctors, nurses, pharmacists, social workers talking together about that specific high-risk patient, figuring out collaboratively what the best plan was to reduce their risk. The sources suggest AI is great at prediction tasks with discrete outcomes, but less so at the complex, nuanced parts of care that need human judgment, empathy, and understanding factors not neatly coded in the data.
So again, it's AI augmenting the humans, not replacing them, especially for those really personalized aspects of care.
Precisely. And that brings us neatly to some of the other big implementation challenges beyond just the data itself. One huge one is model interpretability.
The black box problem.
Exactly. Many powerful AI models, the kinds good at prediction, are like black boxes. They give you an output high risk, but it's really hard to see why they reached that conclusion. What factors drove the prediction?
And in medicine, you really need to know the why, don't you?
Absolutely. For something critical like this, patient safety is paramount. You need explainable AI. Clinicians have to be able to interrogate the AI's reasoning, assess how confident they should be in its prediction, maybe challenge it if it seems off based on their own knowledge of the patient, preferably in real time, not just after something goes wrong.
Lack of transparency hinders trust, then.
Big time. It's a major barrier to clinicians actually adopting and integrating these tools into their workflow. They need to understand at some level how it works, its limitations, how data is handled. Transparency is crucial for safety and buy-in.
What about bias? We touched on data bias earlier.
Yes, and it's a major implementation concern, too. If the historical data used to train the AI reflects existing healthcare disparities, perhaps based on race, ethnicity, socioeconomic status, even gender, like one source mentioned, potentially higher risk for younger women under 65, the AI can learn those biases.
And potentially make them worse.
It could, yeah. It might inadvertently recommend fewer interventions or misjudge risk for certain groups, negatively impacting their outcomes. So practitioners have to be aware, really critically review the AI's output, especially for diverse populations.
Are there other implementation conflicts mentioned?
The sources talk about potential tensions, maybe around service quality versus cost reduction. For example, reducing readmissions is great, but does it automatically mean better service quality from the patient's view? Or maybe the interventions needed to add short-term costs even if they save money long-term. These things need navigating.
And just fitting it into the day-to-day chaos of a hospital.
That's make or break. Seamless integration into clinical workflows is absolutely essential. If the tool is clunky, slow, gives unhelpful advice, or adds extra work, staff just won't use it, it'll fail.
So getting clinician buy-in is key, involving them.
Yes, involving clinicians in development, testing, rollout is vital for building trust and making sure the tool actually helps rather than hinders. And then there are the technical aspects, making sure the system can scale up, that it's always available, that it properly integrates with the hospital's existing systems like the EHR, lab systems, imaging systems, usually through APIs.
Sounds like significant IT work.
It is. And you need solutions for different environments, maybe edge computing if bandwidth is low, handling multiple languages if needed. And it has to be affordable for hospitals of different sizes.
Okay, shifting focus slightly. How can AI help specifically during that crucial discharge phase?
Well, the risk stratification we've been talking about is key at discharge too. Using AI to analyze hundreds of EHR variables to flag risk is much more powerful than a quick manual review.
Beyond predicting risk.
Yeah, sources mention potential for automating parts of the discharge summary. Having AI draft sections from the structured data could save clinicians time and maybe reduce errors. Also, predicting post-discharge needs.
Like predicting if someone will need home care.
Exactly. Based on their history, maybe social factors if available. Optimizing follow-up appointments is another one, predicting who's likely to no-show so staff can intervene proactively.
And I saw something fascinating about using AI, large language models,
Yeah.
LLMs, to simplify discharge instructions. That sounds incredibly useful.
It really does. This addresses a huge problem. You know how discharge instructions can be filled with jargon? Overwhelming, hard to follow.
Definitely.
Well, that confusion leads to patients maybe not taking meds correctly or missing signs they should call about, which increases their risk of complications and coming back.
So the idea is an LLM could rewrite them in plain language.
Exactly. Simplify and personalize the instructions. Make them much easier for the average patient to understand and actually use. Imagine getting instructions tailored to you in clear language, maybe even on a mobile app.
That could make a massive difference in adherence, couldn't it?
Huge potential. Better medication adherence, fewer errors because things are clear, patients feeling more empowered. It all contributes to safer transitions home and fewer readmissions. It's about that continuity of care.
Are there other related discharge uses?
Yeah, things like AI assisting with medication reconciliation, checking the final list against guidelines or potential interactions. Recommending follow-up based on diagnosis, one pilot apparently saw better follow-up rates. Even analyzing patient messages after discharge for potential issues.
So despite all the challenges we've discussed, the potential seems really significant. What's the overall outlook based on these sources? Where's this headed?
I'd say the outlook is cautiously optimistic. There's immense promise here to really transform discharge planning, improve patient outcomes. The expansion of AI in healthcare feels, frankly, inevitable.
But with caveats.
Big caveats. For this to be safe, widespread, and truly successful, those significant barriers must be addressed. The data issues, the interpretability or black box problem, managing bias, ethical considerations, and that critical piece, seamless integration into how clinicians actually work.
So, approach with healthy skepticism. Responsible innovation.
That's the phrase. AI isn't a magic bullet. It's an incredibly powerful tool, but it needs to be used wisely, thoughtfully, as something that augments human expertise. The real value seems to be in using AI's analytical power to find the signal in the noise, like identifying those high-risk patients, so human professionals can apply their skills more effectively.
Like those other examples, AI helping write clinical rules or voice interaction.
Right. It's about partnership. Building trust, ensuring transparency, actively working to mitigate bias, and always prioritizing patient safety that has to be front and center. It means continuous learning, iteration, and a real commitment to ethical principles.
This has been a really illuminating deep dive. We've covered the potential, the real-world evidence, but also the significant hurdles in using AI to tackle hospital readmissions. Thank you for walking us through the sources.
My pleasure. It's a complex but fascinating area.
And thank you all for joining us. We've heard compelling evidence that AI can predict readmission risk effectively. Yet we also heard from the sources that staff sometimes found more value in the AI's prediction prompting human collaboration rather than its specific automated recommendations. So based on all that, here's something for you to think about. What is that optimal balance? How do we design and implement these AI systems so their powerful predictive insights genuinely enhance, rather than clash with, the irreplaceable nuances of human clinical judgment and that vital patient-caregiver relationship? Something to mull over.